Imagine stepping into a hospital room back in September of 1948. You're looking at a 29-year-old woman, and she is just completely bedridden.
Right, she had severe rheumatoid arthritis.
Yeah, her joints are so destroyed, so inflamed that she can barely even move. Then her doctor walks in with a syringe containing this brand new, highly experimental compound. He gives her an injection, and, well, within days, she is actually walking around the ward.
Which is almost unbelievable when you think about it.
Totally. By her third dose, she has essentially checked herself out and is literally downtown going shopping. I mean, it looks like absolute magic, right? Like a switch was just flipped.
It really was. I mean, the profound dramatic transformation of that single patient, it completely shifted the entire trajectory of modern medicine. It established a whole new baseline for what doctors thought might be possible with autoimmune diseases.
And that transformation is exactly what we're exploring today. Welcome to the deep dive. Our mission today is to, well, pull back the curtain on that quote-unquote magic compound, corticosteroids.
It's a massive topic.
It is. We've pulled together a really fascinating stack of sources for you today, ranging from medical history archives detailing that exact 1948 discovery to, modern pharmacology textbooks, and even some recent critical care trial data.
Yeah, we're covering a lot of ground.
We are. We're going to look at the massive power these drugs hold, the incredibly dangerous side effects they can unleash, and the absolute golden rule of medicine when it comes to managing them. Basically, why you never, ever stop taking them abruptly.
That is so crucial.
But before we get into the dark side of that miracle, we really need to clear the air. Because when we say the word steroids, we have to erase a very specific pop culture image from our minds. We are not talking about bodybuilding.
Oh, absolutely not.
There's no muscle building, no roid rage happening here at all.
Yeah, and that misconception trips up a lot of people, even nursing and medical students in their very first weeks of training. Anabolic androgenic steroids are synthetic derivatives of testosterone. They are specifically engineered to build muscle mass and, well, enhance physical performance. Corticosteroids, on the other hand, operate in a totally different biological arena. They are anti-inflammatory, immune-modulating hormones that are related to cortisol. They manage the body's stress response, metabolism, the immune system. Basically, they prepare the body to survive severe physiological stress, not to, win a weightlifting competition.
So to understand what these drugs are actually doing in hospitals today, we have to go back to the frantic race to isolate them in the 1930s and 40s. Because scientists knew the adrenal gland, those two little triangular organs sitting on top of your kidneys, they knew it was doing something vital to keep us alive.
Yeah, if they removed the adrenal glands from an animal in the lab, it died. They just didn't know what the chemical was.
Right. It was one of the great medical mysteries of the early 20th century. You had this intense race between two brilliant scientists working mostly independently, Edward Calvin Kendall, who was a biochemist at the Mayo Clinic, and Thaddeus Reichstein, a chemist at the University of Basel in Switzerland.
And they were painstakingly trying to isolate active compounds from the adrenal glands of oxen and sheep.
Which sounds exhausting.
Oh, it was grueling bench chemistry, just pulling out these distinct microscopic steroid molecules and labeling them alphabetically, compound A, compound B, compound C, and so on.
And Kendall eventually isolates this compound E, which later gets named cortisone. But having the chemical in a vial doesn't cure anyone. The clinical spark, the actual application to human disease, that came from a rheumatologist named Philip Showalter Hensch.
Yes.
And his observation is just brilliant because it's so strange. He noticed that his severe arthritis patients would suddenly go into spontaneous remission if they got pregnant, or, weirdly enough, if they developed jaundice.
Which led to his substance X theory. Hensch theorized that pregnancy and jaundice were causing the body to flood itself with some unknown circulating hormone, likely from the adrenal gland, that was powerfully suppressing the disease.
That makes sense.
Right. The logic being that if the body could naturally turn off the inflammation of arthritis under certain conditions, maybe doctors could induce that state artificially. So he badgered Kendall to synthesize enough of this compound E to test it on a human. And that brings us right back to that 29-year-old bedridden woman in 1948.
She gets up and goes shopping. It makes international headlines. Cortisone is just universally hailed as a miracle cure. And looking at the historical timeline in our sources, they won a Nobel Prize for this almost immediately.
What's fascinating here is the sheer speed of that recognition. In 1950, Hensch, Kendall, and Reichstein jointly won the Nobel Prize in Physiology or Medicine.
Why 1950?
Yeah, less than 15 years from the early, messy isolation work in the lab to the most prestigious science prize in the world. I mean, a bench-to-bedside timeline that fast is practically unheard of today.
But the euphoria crashed hard. Within just a couple of years, doctors started seeing the horrifying backlash of this supposed miracle. Patients who stayed on high doses of cortisone long-term, they started developing physical deformations.
Yeah, the side effects were severe.
Their faces rounded out into a moon face shape. Their skin thinned like paper, bruising at the slightest touch. Their bones became brittle. They developed severe diabetes, psychiatric disturbances ranging from mania to depression. And most terrifyingly, if they suddenly stopped taking the drug, they would collapse into shock. Some of them died.
The initial rollout of cortisone perfectly illustrates a recurring pattern in medical history. A transformative discovery is completely oversold as a cure-all, and then harsh clinical reality sets in, forcing a recalibration. The central tension of corticosteroids was established right then in those early years. It is an extraordinarily powerful tool that, if mismanaged, is lethal.
Okay, let's get our definition straight. Because diving into the pharmacology textbooks, defining what a corticosteroid actually is depends entirely on who you ask in the hospital. If you ask a bedside nurse versus a pharmacologist, you get two different answers.
You really do. The textbooks use corticosteroid as an umbrella term. It includes two distinct families of hormones produced in the adrenal cortex. First, you have glucocorticoids, which handle glucose regulation, metabolism, and suppressing inflammation.
Okay, that's group one.
Right. And second, you have mineralocorticoids, like the hormone aldosterone. Mineralocorticoids govern sodium and water retention. They are the master regulators of your salt and fluid balance. Because both are manufactured in the adrenal cortex via the same biological pathway, technically they are both corticosteroids.
But when a nurse tells a colleague, like, hey, my patient in bed 4 is on steroids, they're almost never talking about the salt balancing ones.
Exactly. At the bedside, the everyday clinical definition of steroids almost exclusively points to the glucocorticoid family. We're talking about synthetic drugs like prednisone, dexamethasone, and hydrocortisone. These are the heavy hitters prescribed for asthma flares, autoimmune diseases, or severe allergic reactions.
And what about the others?
Mineralocorticoids, like fludrocortisone, are prescribed far less frequently, usually just for specific conditions where the body literally can't retain sodium, like Addison's disease.
Okay, let's unpack this. To really grasp why that one injection in 1948 acted like magic but then turned so dangerous, we have to understand how these drugs fundamentally hijack the body's natural systems. And looking at the physiology guidelines, the easiest way to visualize this is to think of the thermostat in your house.
I love that analogy. The hypothalamic pituitary adrenal axis, the HPA axis, it operates on the exact same principles as a home heating system.
So the HPA axis is your body's built-in corticosteroid factory. The thermostat on the wall is your hypothalamus in the brain. It senses the temperature, or in the body's case, the stress level. And when things get tough, it sends a chemical signal.
Right.
That signal is a hormone called corticotropin-releasing hormone, or CRH. The CRH travels to the furnace controller, which is your pituitary gland. The pituitary receives that signal and sends its own chemical messenger down to the basement.
And that messenger is adrenocorticotropic hormone, or ACTH.
Right, ACTH. And the furnace in the basement is your adrenal glands. The ACTH tells the adrenal glands to turn on and pump out the heat, which is the hormone cortisol. Once the house is warm enough and the stress is managed, the thermostat on the wall senses the heat, stops sending CRH, and shuts the whole system down. It's a classic negative feedback loop.
And your body runs this furnace continuously. Under normal non-stress conditions, a healthy adult's adrenal glands produce roughly the equivalent of 5 to 10 milligrams of synthetic prednisone a day.
Oh, wow. So we always have a baseline.
We do, and this production follows a strict daily rhythm, peaking in the early morning hours to essentially wake your body up and prepare it for the day. Then it drops to its lowest point late at night so you can sleep.
So when we give a patient a synthetic corticosteroid pill, we are basically pumping massive amounts of artificial heat into the house. And the clinical versatility of this artificial heat is staggering. Let's look at how this plays out in modern medicine, starting with the disease that started it all, rheumatoid arthritis. Here, the drug is used as a bridge therapy.
Right. Rheumatoid arthritis is an autoimmune disease where the body's own immune system aggressively attacks the joint linings. When a patient is in agonizing pain, the long-term disease-modifying drugs can take weeks or months to start working.
That's a long time to wait in pain.
Exactly. So corticosteroids serve as the bridge. A doctor gives a dose, and within 24 to 72 hours, it violently suppresses that immune activity. It halts the destruction temporarily, buying time for the slower-acting medications to finally take over.
But you don't always want to flood the whole system. Let's look at asthma. This is where the delivery method completely changes the strategy. You can keep the treatment localized.
Yeah, matching the route of administration to the clinical need is vital. For everyday asthma maintenance, a patient uses an inhaled corticosteroid. The medication goes directly into the airway tissue, suppressing the inflammation right where the problem is occurring.
Which is great because it stays out of the rest of the body.
Right, because it's inhaled, very little of the drug absorbs into the systemic bloodstream, which minimizes side effects. But if a patient comes into the emergency room with a severe acute flare-up of chronic obstructive pulmonary disease, COPD, that localized inhaler is useless.
They need the whole house heated systemically.
Yes. They require a short, powerful burst, usually a 5-day course of oral corticosteroids like prednisone, to systemically crash the inflammation and open those airways up.
Now, here's where my brain starts to struggle with the logic in our sources. Septic shock.
Oh, yes.
We've got a patient in the intensive care unit who is fighting a massive life-threatening bacterial infection. Their blood pressure is crashing. And the protocol suggests giving them an immune-suppressing drug. I mean, that sounds like throwing water on a drowning man. Why would we turn off the immune system when there's a massive infection?
It seems completely counterintuitive, doesn't it? But the key here isn't the immune suppression. It's a concept called adrenal reserve. In severe septic shock, the physiological stress is just off the charts. The patient's blood pressure bottoms out, and their organs are failing.
Right.
In some cases, the sheer magnitude of the illness outstrips the adrenal gland's physical ability to manufacture enough cortisol to keep the cardiovascular system running. The furnace simply can't keep up with the cold. The patient is running on empty.
I see.
So doctors will administer low doses of intravenous hydrocortisone, not to suppress inflammation, but to literally replace the survival hormone the body has run out of.
Okay, so you are just trying to keep the blood pressure up by replacing the baseline cortisol they are missing.
Yeah.
But the critical care data we looked at shows this isn't a universally accepted practice, right?
The practice is heavily debated. Over the last 2 decades, multiple large-scale clinical trials have yielded really conflicting results on whether this low-dose hydrocortisone strategy actually improves overall survival in septic shock.
Really? How so?
Well, some trials show it helps stabilize blood pressure faster, but others show no significant mortality benefit and perhaps even an increased risk of secondary infections. Consequently, the international guidelines remain conditional. It is a highly nuanced decision made at the bedside by the clinician.
That makes sense. It's a desperation move when the body's own factory is failing. But these drugs aren't just for immune suppression or stress response. Our sources highlight a fascinating use in obstetrics. Antenatal steroids for premature labor. We give an injection to a pregnant person, and it fundamentally changes the physical structure of the fetus's lungs.
Yeah, we use specific corticosteroids, usually betamethasone or dexamethasone for this. If a patient is at high risk of delivering prematurely, a single course of corticosteroids is administered to the mother. The drug crosses the placenta and actually accelerates the production of lung surfactant in the fetus.
And surfactant is the stuff that stops the lungs from collapsing, right?
Exactly. It's the slippery substance that keeps the tiny air sacs in the lungs, the alveoli, from collapsing when we exhale. By speeding up that lung maturation, you drastically reduce the risk of respiratory distress syndrome when the premature baby takes its first breaths.
That's incredible.
It proves that glucocorticoids do far more than just quiet immune cells. They can trigger rapid, life-saving developmental changes.
Seeing how powerful this hormone is across all these different scenarios, the logical pushback from a patient, or, you listening to this, would be, if a short 5-day course of prednisone makes my severe COPD feel amazing, why not a 2-month course? Why can't I just take this drug until I am 100% cured and then just toss the bottle?
Answering that brings us to the single most important clinical rule in our entire deep dive today, the tapering rule.
The golden rule.
Yes. If a patient takes exogenous corticosteroids, meaning synthetic hormones from a pill, an IV, or an injection, at doses above that natural 5 milligram physiological baseline for longer than roughly 2 to 3 weeks, they must be tapered off slowly. The dosage has to be gradually reduced over time. They can never, under any circumstances, be stopped cold turkey.
Going back to our thermostat analogy, this makes perfect sense. If you start taking high-dose pills every day, you are flooding the house with artificial heat. You are essentially outsourcing your cortisol factory to a plastic pill bottle.
Right.
The HPA axis, the thermostat on the wall, senses all this synthetic cortisol floating around in the blood and registers that the house is boiling. It completely shuts down. The hypothalamus stops sending CRH. The pituitary stops sending ACTH. And without that chemical signal telling them to work, the adrenal glands down in the basement don't just pause, they physically shrink. They atrophy from disuse.
Yeah, the architecture of the adrenal cortex literally wastes away. The body becomes completely biologically dependent on the pill bottle for its daily cortisol. If a patient suddenly stops taking that medication, they trigger a catastrophic twofold medical emergency.
What happens first?
First, the underlying disease they were suppressing, the crippling arthritis or the inflamed airways, can violently flare back up because the anti-inflammatory shield has been dropped. But the second problem is much more immediate and far deadlier.
The Addisonian crisis.
Yes, an acute adrenal crisis.
Right.
Because the adrenal glands have been dormant and shrinking for weeks or months, they cannot simply be flipped back on like a switch. Full structural and functional recovery of the adrenal glands can take weeks, months, or in severe cases of long-term use, up to a year.
A year?
Yeah.
No.
So stopping the pills abruptly means the body suddenly has absolutely zero cortisol to manage baseline stress or maintain blood pressure.
Without any cortisol, what is actually happening to the patient in that moment?
It is a profound, life-threatening state of shock. The cardiovascular system loses its tone, so blood pressure plummets dangerously low. The patient experiences overwhelming fatigue, severe nausea, vomiting, and acute abdominal pain.
And it messes with their salt balance, too.
Exactly. Because the synthetic drug often had some mineralocorticoid activity as well, stopping it throws the body's salt balance into chaos. The patient's sodium levels crash, and their potassium levels spike to ranges that can cause fatal heart arrhythmias. Left untreated, an adrenal crisis can kill a patient in a matter of hours.
And reading through the nursing pharmacology text, the scariest part is the illusion of health. Feeling fine while on the drug gives you absolutely zero indication of what's happening internally.
None at all.
A patient could feel fantastic, totally symptom-free, but their adrenal glands are completely dormant. You cannot trust how you feel to decide when to stop the medication.
That illusion of health is why prescribing these drugs requires such meticulous management. Short courses, typically under 2 weeks, generally don't require a taper because the adrenal factory hasn't had enough time to completely shut down and physically atrophy.
Right.
But anything beyond that 2 to 3 week window requires a carefully mapped tapering schedule. You have to slowly lower the artificial heat to coax the thermostat into turning the body's natural furnace back on.
Because the stakes are a matter of life and death, precision timing dictates everything. And here's where it gets really interesting, especially when we look at recent medical history. Let's talk about the COVID-19 pandemic, specifically the recovery trial out of the UK. This was a massive, highly publicized moment for corticosteroids.
It was huge. The recovery trial provided one of the most consequential therapeutic breakthroughs of the entire pandemic regarding the steroid dexamethasone. Researchers discovered that administering low-dose dexamethasone significantly reduced mortality, it saved lives, in hospitalized COVID-19 patients who were so sick they required supplemental oxygen or mechanical ventilation.
But the nuance in that trial data is crucial. Didn't it also show that if you gave dexamethasone to mild cases, like people early in the infection who didn't need oxygen, it offered no benefit? And the data suggested it might actually harm them.
Yes. The paradox of the recovery trial is a masterclass in understanding how immune suppression works. In severe late-stage COVID-19, the virus itself is often no longer the primary threat.
Right, it's the body's reaction.
Exactly. The danger is the body's own immune system overreacting and destroying the lung tissue, the infamous cytokine storm. Dexamethasone damped down that fatal late-stage inflammation.
And early on.
Early on in the mild phases of the disease, the virus is actively replicating. You desperately need your immune system awake, aggressive, and fighting to clear the virus. If you introduce a powerful immunosuppressant like a corticosteroid too early, you disarm the body's natural defenses, allowing the virus to replicate unchecked.
Context is everything. The benefit of the drug depends entirely on the exact phase of the disease, not just the name of the disease itself. Giving it on day 2 is dangerous, but giving it on day 10 is life-saving.
Timing and disease pathophysiology dictate the outcome entirely.
Let's clarify one more thing, because if I'm a nursing student reading a chart, I might see a patient taking ibuprofen, which is an NSAID, and another taking prednisone, a corticosteroid. Both are classed as anti-inflammatories. Both bring down swelling. How do we distinguish how these neighbors operate?
Mechanistically, they operate in completely different biological universes.
Oh.
Oh, yeah. NSAIDs like ibuprofen or naproxen work near the surface level of the inflammatory cascade. They act by blocking specific enzymes called COX enzymes. By inhibiting COX, they stop the body from producing prostaglandins, which are the chemicals that cause localized pain and swelling. It's a very targeted, localized blockade.
Okay, so how do corticosteroids do it?
Corticosteroids go infinitely deeper. They are lipid-soluble, meaning they pass right through the outer membrane of a cell. Once inside, they bind to specific glucocorticoid receptors in the cytoplasm, and then that entire complex travels straight into the nucleus of the cell to physically alter gene transcription.
I love visualizing it this way. NSAIDs are like putting up a physical roadblock on a street to stop traffic. Corticosteroids bypass the street entirely, walk into City Hall, sit down at the mayor's desk, and completely rewrite the city's zoning laws.
That's a perfect way to look at it. By altering gene transcription in the nucleus, corticosteroids are literally commanding the cell's DNA to stop manufacturing inflammatory proteins while simultaneously turning on the genes that produce powerful anti-inflammatory proteins.
Wow.
It is a profound systemic cellular override. It dictates cellular behavior from the genetic code upward.
Which brings us to a huge misconception that we really need to stamp out before we wrap up. We've talked about how powerful the cellular override is. Does a corticosteroid actually cure an autoimmune disease?
No, it does not. And it is vital for clinicians to communicate this clearly to patients. Corticosteroids do not cure the underlying pathology of diseases like rheumatoid arthritis, lupus, or severe asthma.
They just mask it.
They merely suppress the symptomatic expression of the disease. They hold the monster in a cage. If you taper off the steroid without introducing another medication that actually modifies the disease process, the monster's still there and the symptoms will return.
So to bring all of our sources together for you listening, we've covered a massive amount of ground today. We learned that these synthetic marvels don't invent a new biological function. They hijack, amplify, and prolong the stress response your adrenal cortex already manages.
Right.
We saw their origin in the desperate bench chemistry of the 1940s. We explored their staggering versatility, from acting as a bridge in arthritis to rescuing failing blood pressure and septic shock to rapidly maturing fetal lungs. And we hammered home the absolute non-negotiable necessity of the tapering rule to avoid a fatal adrenal crisis.
And the reason this information is so critical, whether you are a medical professional managing a ward or just a curious learner, is that corticosteroids remain one of the most widely prescribed drug classes on the planet.
They're everywhere.
From treating eczema and severe allergies, to preventing organ transplant rejection, to managing viral pneumonia, their footprint in medicine is inescapable. But that power requires vigilance. Managing a patient on long-term steroids means meticulously monitoring blood glucose, because these drugs spike sugar levels.
Right, diabetes risk.
It means protecting bone health to prevent osteoporosis. It means looking out for those Cushingoid physical changes, the redistribution of fat to the face and the center of the bottle. Ensuring patient safety with corticosteroids is one of the highest stakes responsibilities in everyday clinical practice.
So what does this all mean? It means we are wielding a double-edged sword that interacts intimately with our most ancient biological rhythms. And I want to leave you with one final thought to mull over, something that builds on exactly how these drugs work. We learned earlier that corticosteroids operate by going deep into the cell's nucleus and altering gene transcription. We also learned that our body's natural HPA axis, our internal thermostat, has a strict circadian rhythm, peaking our natural cortisol early in the morning and dropping it at night.
Yes, our natural biological responses are heavily dictated by the clock.
It makes you wonder, if our natural hormones are tied so strictly to the time of day, could the exact hour you swallow a synthetic corticosteroid pill fundamentally alter which immune genes are turned on or off?
That is a great question.
By choosing to fight against or align with that natural morning peak, can a drug's effectiveness, or even its side effects, be manipulated simply by looking at a watch before taking the dose?
The intersection of circadian rhythms and drug timing is called chronopharmacology, and it is honestly one of the most fascinating frontiers in medicine today. It is a perfect question to keep exploring.
Think back to that 29-year-old woman in 1948, walking out of the hospital to go shopping. It looked like magic.
Yeah.
But as we now know, in medicine, there is no magic, only incredibly powerful mechanisms that demand our deepest respect, careful timing, and relentless understanding. Thank you for joining us on this deep dive into corticosteroids.
Keep questioning the mechanisms, and goodbye until next time.